is the video for the Do Influence, and I'll just go ahead and get started with the questions. So my name is Erin Marten, and I am a certified nurse midwife, which is an advanced practice registered nurse, but I specialize in obstetrics and gynecology. So my focus is normal childbirth and any sort of gynecologic care that doesn't involve surgical procedures. There are a few in-office minor procedures that we are able to do, but I'll get into that in just a little bit. So the training for nurse midwifery is a master's degree or above in nursing. Most RNs are able to practice, well, I guess all RNs are able to practice with a bachelor's degree at the most, an associate's degree at the minimum. So anybody who wants to become an advanced practice nurse needs to get a master's degree, and that is usually broken down into different categories. For example, family nurse practitioner is generally an avenue that people can focus on. Mental health nurse practitioner, women's health nurse practitioner. And then, of course, nurse anesthetist. But there's also certified nurse midwife. So in my particular situation, I knew that I wanted to be a midwife and went to nursing school in order to be a midwife. So that was always the goal. So I went ahead and went straight for the bachelor's degree and got my registered nurse license when I got my bachelor's degree. So that was a 4+ year degree, counting all of the prerequisites that you have to do. And then I spent a year or so working on a step-down unit and getting kind of general nursing knowledge. And then I applied for nurse midwifery school and then continued to work on the floor as I was doing nurse midwifery school. So master's degree is generally about 2 years if you go full time. Of course, you can always choose to go slower than that and take 3 or 4 years to get your master's degree. I also went ahead and pursued getting a doctorate in nursing practice. So a doctorate in nursing practice is different than like a PhD in nursing, in that PhDs do a lot of research, write a lot of papers, and doctorate of nursing practice or doctors of nursing practice take that research that the PhDs are doing and other researchers are doing, and then figure out how to best implement that into practice. So there's a lot of quality improvement that goes along with it. There's a lot of rapid cycle improvement type of things. But then, of course, also we get a little bit extra training in education and leadership because pursuing a doctorate in nursing practice kind of sets you just a little bit apart from people who have a master's in some sort of nursing, in that, you're kind of set up to be leaders, and, you're expected to maybe pursue jobs with administration or higher education. Typical day for me, I have 2 typical days. So I have clinic days and then I have call shifts. So in my particular practice, there are a handful of midwives who share a call schedule. And this, of course, can look different in many different types of practice. It depends on how many people are in the practice. It depends on what kind of practice, whether you are primarily working in the hospital or whether you're doing out-of-hospital births, like in a birth center. But in my particular practice, we have multiple midwives who share a 24-hour call, and then we spend 2.5 days in clinic. So contractually obligated to work at least 40 hours a week. Of course, it often ends up being more than that. A clinic day involves seeing patients in the clinic, anywhere from 15 to 22 or 23 patients, depending on what types of visits they are. But seeing patients in the office includes obviously a lot of prenatal appointments. So checking up on the pregnancies, listening to the baby's heartbeat, measuring the belly, addressing any sort of concerns that they have. And then also doing gynecologic care. So like annual exams such as pap smears, and then other types of visits would be contraception education, birth control prescription, talking about menstrual cycles, troubleshooting, things like that. And so there are problem visits, and then there are also annual visits, and then prenatal visits, I would say, are about the three categories of visits that we have. A call schedule or a call shift is a 24-hour call shift for us. We start at 6 p.m. and then go to 6 p.m. the next day. Depending on how busy we are, that entire call shift could potentially be spent at the hospital, but we do take call from home. Either we are at the hospital with a patient in labor, or are seeing patients in the triage who are coming in, think they might be having contractions, think they might be in labor, or think that their water might have broken, those kinds of things. But if we're home, then we're available for phone calls to kind of do phone triage. Maybe it's somebody who isn't sure if their contractions are strong enough to go into the hospital, or somebody who has some sort of question about some pain that they're having or something like that. In our practice, or my practice, we do labor sit. So when somebody goes into the hospital in labor, we go in with them and manage the labor from the hospital, work really, really closely with the nurses. And then, of course, as the woman gets closer to delivery, more and more comfortable, we are there in the room with them, trying out different comfort techniques, helping them move around the room, and then obviously there for delivery, and then for a time postpartum until they are kind of medically stable. What made me decide to go into the field is, so I didn't always want to be a midwife. In fact, in a life before midwifery, I worked in food service. I was pretty active in the culinary world, believe it or not. And was really happy doing that. Although I could see that the schedule that chefs have isn't exactly conducive to a super happy family environment. Lots of late nights, really, really tough work, lots of hours. Of course, midwifery is that also, but in a little bit of a different way. But I read a book about midwifery, and it was just fascinating to me. And it was a book about kind of more natural childbirth. And it really just kind of struck me how women are so powerful, and in a perfect situation, that this process can be so seamless from the beginning to the end, where it just it happens, and a woman just kind of knows intuitively what to do. Of course, I have learned since then that that's not always the case. So one thing we always kind of say in midwifery education is that we are experts in natural, quote unquote, physiologic childbirth, so that we can recognize abnormal childbirth. Because very frequently there are abnormal things that happen, and it's our job to kind of see those things happening and kind of figure out the next steps. So it's not always, this beautiful, twinkling lights, beautiful experience. in the way that people think it is. It can be a very beautiful experience when things don't go quite as planned. But it is important, I believe, to have a knowledgeable person present who knows when things are becoming abnormal and it's time to get help, or make a different plan. There's courses in college or high school that are most helpful in preparing for this particular career path. Obviously, there's a lot of math and science involved. I personally was never really great at math. So I had to work really, really hard at that on college, or on math in college. In my undergrad, we didn't really do a whole lot in my graduate studies, but I had to work really hard, and I had to really take that seriously and kind of understand how important it was for me to have a really good understanding of this. Not just in administration of medicines or calculating how much medicine to give to somebody, but understanding statistics, and the way that research is calculated, and how research is determined to be good quality research as opposed to bad quality research. That's a really important something for a healthcare provider to understand. I mean, it is our job to continue to stay current once our schooling is over. Medicine changes all the time, and research changes all the time and advances. And so it's really important to be able to read the newest research and understand why it's good quality. And a lot of that comes from statistics. So biostatistics. So that's really, really important. Let's see. In my particular situation, I went to nursing school a little bit later in my 20s. So I had a little family started by that point in time. And then when I was in graduate school, I was a single mom of 2 children. So, the question is, how did you maintain focus to study and prepare for your exams? I would say I didn't have any other choice. My priority was to be successful at midwifery school so that I could provide myself and my children better than what we had, which was not bad. The salary of a nurse is okay, but I wanted to succeed so badly that staying focused for me was a priority, and it just wasn't something that I questioned. I guess I should also say that my entire graduate education was done at an online school. So that is something that I know very well, how to be successful at online school. It, of course, didn't come easy, but it is important to stay motivated, and it's nice because it's, people assume that online schooling is, you just do things whenever you have time, but there are deadlines. Things need to be turned in at a certain time. Tests need to be taken at a certain time. Exams need to be taken at a certain time. So, that helps stay motivated, but I eventually learned that I had to make the most of the time that I had free to study, because I wasn't sure if I was going to get that time again. So that was, kind of how I maintained focus to study. It just, there wasn't another option for me. I guess I would say, since I am a little bit crazy and enjoy online schooling, I'm currently pursuing a master's in public health and maternal and child health as well. I have come to believe very strongly that public health is as important, if not more important, than direct health care. And at the very least, those 2 areas should be able to work together really well. I have learned so much in my public health education that I didn't really learn in my midwifery education about, why people are, have the health that they have, other than just genetics. And so that's been really helpful to me, I think, to kind of as like an adjunct to my personal health, to my direct healthcare job, because I am able to kind of understand patients a little bit differently, and evaluate not just their health, but where they live, what their income is, what kind of food that they can afford. Do they have opportunities for exercise? Do they have a car? Do they get to us on the bus? I mean, these things all influence a person's health state. So that has been really, really helpful to me. I guess consider a public health view while also considering a direct healthcare route. I think that's been really helpful and made me a much more comprehensive provider. I guess as far as kind of midwifery specifically, midwifery is something that is becoming much more understood, accepted, and demanded method of obstetrics and gynecology. Midwives have been around since the beginning of time, and there was a period in time in American history, particularly, where midwives kind of fell out of favor, for the sake of doctors and hospitals. Midwifery is different than obstetrics and gynecology, even though we use all of the same education, all of the same research, we follow all of the same guidelines. But what sets us apart is the model of care that we follow. So I mentioned earlier that midwives, or at least in my practice, we labor sit with the patient the entire time that they're in labor. We spend a lot more time in the clinic setting, talking to patients, getting to know patients, provide extensive education, and very much take the view of shared decision making with the patient. We have a very wide range of patients who come to us, and that is anyone from, people who are seeking out the most natural process, with absolutely no intervention, to people who are having a repeat C-section. So we see the entire gamut of patients. But like I said, what sets us apart is the relationships that we develop with them, and the time and the care and the consideration and the compassion that we give to patients. And we generally have very high satisfaction ratings because of that. Doctors provide really excellent care as well, and we cannot do what we do without doctors, because if somebody does need a C-section or a vacuum delivery or a hysterectomy or a uterine ablation, that obviously is referred to a physician. So it's really important that we work hand in hand with each other in order to have the best outcomes. But our approaches and models of care are just slightly different. But both, I think, very, very necessary. I think that is it. thank you for your time, and I strongly encourage midwifery model of care as a adjunct to that with a public health education. So thank you very much.